glaucoma. Now we have the last talk of the session by Dr. Steven Mansberger, and he's going to talk on how do you know that you are losing the battle. Dr. Steven, please.
Thank you. Thank you for the organizers for having me be here. These are my disclosures. They don't have much to do with what I'm going to be talking about today. So, this is probably well known to the audience, but we talk a lot about diagnosing glaucoma and making sure that it's the right diagnosis. But really, once you have the diagnosis, the key thing is determining the rate of progressive glaucoma. This is going to help predict, as Alan Robbins said, what the risk of going blind is over time. I'm also going to talk about structural progression and how you detect that, and then maybe some new ways of detecting progression. So here's this case. You have a 65-year-old female who's in your clinic. Her pressure is 18. Her central corneal thickness is 530 microns. And the question you have to yourself is, gosh, is her glaucoma progressive? And if so, how fast? And what you do notice on this exam is you see this disc hemorrhage here. And this disc hemorrhage, is going to be associated with progressive glaucoma. So this is kind of what we're going to talk about today. How do you approach this lady? So what does visual field progression look like? It could be a deepening of an existing scotoma, so the sensitivity in that one scotoma gets worse. It could be a widening where the visual field defect becomes a little bit larger, or it can be a completely new area of damage. And there's two ways of looking at, you look at event-based testing, looking at whether or not this looks worse, according to a certain baseline, and there's these rate-based changes. So you have two kind of slides here where you can look and see down here, when you're plotting mean deviation over time, the mean deviation is pretty darn stable. Where on this patient here, you can see the mean deviation is going worse relatively quickly. This is the person you really need to worry about. This is the one you need to be aggressive about the treatment. This is the one you need to talk about adherence, like Dr. Robin had talked about. And this is the one you may have to just operate on. So it's really, really important to determine progression and determine the rate of progression. So there's a really nice paper by David Crabb in IOVS in 2014, where he took all of the visual fields from the National Health Service. They had 400,000 visual fields, and over about a 15-year period. And what I want to look at on these visual fields is how often they went blind or they lost vision. And then he determined, visual impairment with mean deviation worse than -14, and blindness as defined as a visual field defects or visual field sensitivity less than -22 decibels. And what he was looking at is, like, for example, this patient here at baseline, how often they had a little bit of vision loss but never reached this visual impairment, or somebody like this who became blind over time. And so this is just kind of a point cloud of each of the patients, and each color means a certain thing. So the green means that they never developed visual field loss over their lifetime and they became blind, where the yellow mean they became visually impaired, and the red shows that they became blind. And what you can see here is that actually, and there's one other color, there's blue. I'm not sure if you can see that. The blue actually says they've been improved. And so what you can see is about 7.5% had a rate worse than 1 decibel per year. And 1 decibel per year, you'll remember, is going to be the rate in which somebody is likely to become visually impaired over their lifetime. 3% were considered fast progressors at more than 1.5 decibels per year, but 33% had positive visual fields. They actually got better over time, maybe just because they got better at the visual field. 90% of them, 90% of blindness were worse at baseline, so those patients that came in that already had progressive glaucoma or severe glaucoma, and about 5 to 7 became blind over their lifetime. So what rate of loss is significant? So just like I showed you here, the David Crabb study was about 1 decibel per year. The EMGT also had about a very similar 1 decibel per year. Rossetti, again, had 1 decibel per year. So all these studies are kind of showing the same number, and if you want to compare that to the visual field index, it's about 2.5% per year. So those are the patients that you're going to get really aggressive when they have faster loss. Now, if it's a 50-year-old who's got maybe a 1% per year, you might be more aggressive than an 80-year-old who's having 2.5% per year. The other thing about these studies show us that we need to retest abnormal visual fields, and this comes from the OATS study, where at least 66% of visual fields that were abnormal became normal on repeat testing. So just repeating the visual field before you advance therapy, I think, is a key feature as well. So here's some examples. This is a visual field where it looks like they had some loss on top and below. You might say, oh gosh, this is an artifact from the lens being too far away from the eye, and then they repeat it, and the visual field defect goes away. Here's another example. Looks like pretty classic glaucoma where they get a visual field defect right there at fixation. They repeat the visual field, and lo and behold, it goes away. And here's another example where it looks like there might be a nasal step here, pretty obvious. Again, they repeat the visual field, and it went away. So again, I don't advance therapy unless I can confirm that the visual field is indeed getting worse. And then finally, when to check 10-2 visual fields. That's become kind of a hot topic because our 24-2 visual fields don't have a lot of presentations in the center. The 10-2 visual fields has 68 points in the central degrees, where there's only about 4 with a 30-2 or 24-2. And a fair number of patients who have normal central testing with 24-2 have abnormalities with the 10-2. The second thing we heard already today was about the importance of looking at the optic nerve. And if you're not looking at the optic nerve, you're going to miss at least 50% of those patients who are getting worse. This is a paper that we published a while back looking at what happens to the optic nerve, because we keep telling people they need to look at the optic nerve, but we don't tell them what to look for. And if you look here on the left, you have a normal optic disc, and this focal notching is actually really uncommon. It's only about 16% of the way the optic nerve changes, where you'll get regional or diffuse rim thinning. That's the most common at 54%, and excavation, where the rim just seems to be undermined. That is the most common form of progressive glaucoma by the optic nerve, at least on disc photos. And finally, nerve fiber layer defects occur uncommonly. So those classic pictures of a notch or a nerve fiber layer defect, those are actually uncommon in glaucoma. It's really this generalized thinning. So these are some examples. Here's a photo of somebody who got worse, and what you can see here is this vessel here lost its supporting structure. You can also see this enlargement of parapapillary atrophy. There's also some more thinning up here. So this is an example of maybe a focal thinning. This is a person who you can see has a disc hemorrhage. If you see a disc hemorrhage, take a photo because that's where the action is going to be. And you can see this enlargement of a nerve fiber layer defect, also a nerve fiber layer defect up here. And then finally, this is not a subtle. This is a patient who had photos way back when. It was on volume 2, volume 3, and I ended up pulling out volume 1 one time, and I'm like, oh my God, their optic nerve really has changed over a long time period. But this is generalized cupping, and you see all these changes in the vessels, this parapapillary atrophy, et cetera. So we talked a little bit about disc hemorrhage already. Examine for non-glaucomatous causes. Ask about non-adherence, because if you see a disc hemorrhage, it could mean that they weren't using their drops and they're just trying to make you happy and using the drops just before their visit with you. And advanced therapy if the benefits outweigh the risks. And I always take a photo because that's where the location of damage is going to be in the future. Finally, I'm just going to talk quickly about algorithms for OCT. We've got 3 different ways of checking the OCT for progression. We've got our sectoral scan, we've got our circle scan, and we've got our macular scan. The circle scan is the highest sensitivity to determine progression. It's common to all devices, is easy to plot, and there's some differences in measurement techniques. And so this is my most common one. But the macular and ganglion scan can be really great when the patients have a lot of parapapillary atrophy. There's some data suggests it's better for detecting myopic glaucoma from just myopia. And Finally, the sectoral scan with the minimum rim width, that's something that we have done quite a bit at Legacy Diverse in Portland, and we think it might be better for patients with more severe glaucoma. There's less of a floor effect. So some take-home points is visual field loss of 2.5% per year or 1 decibel a year is a risk for progressive glaucoma or for visual field disability. Photos or on-face imaging can be really useful to document a disc heme and changes near the vessels. Disc heme is a location for future damage, and use the right OCT for the right patient. Thank you.
Yeah, thank you, Professor Steve, for really giving a clear picture that how to assess the rapid progression and on perimetry and the disc evaluation and OCT. So I'm sure it will help in the